Okay. So this is Purim in Israel, which means that we are wearing masks and you're not supposed to recognize anybody. So my mask was a Ghana mask. And we'll start this last meeting with saying good afternoon to everybody. And start by sharing some good news with you. I hope as good as for you as it is for us. I will be coming to Kumasi on the next week, on next Saturday, joined by one of the senior nurses from our NICU, which Elon will present in a minute. I will be coming with the ambassador for the closing ceremony and the certificates for this workshop. And I will be more than happy to meet all these Black faces in person and do clinical rounds in the NICUs and do some work together. The plan for the whole week will be delivered to everybody by Rita and Ashura. And Elon, please introduce Liraz. And Liraz, raise your hand. Okay, this is
okay,
Liraz.
Aggie meant that she will be happy to meet all the black boxes where she doesn't see the faces. This is what she meant.
Yes, I will.
And Liraz is one of our nurses in the neonatal intensive care unit, and she has a lot of experience with little babies, with babies at all. I'm really excited that she's going because I think that you're all gonna love her. There's one thing that I'm asking, we want her back after she finishes because you might get in love with her and want her to stay with you. I'm sure she will be learning a lot of you, and just take the opportunity to learn from her also. And that's it. And we're really happy that it was possible that the Ministry of Foreign Affairs, what we call Mashav, the section of international cooperation, managed to send Aggie and Liraz to Ghana for the end of this workshop to meet you all, and also to do a few rounds in the units to see how they're faring, to see if, you know, to do some rounds together, to hear you, to see you. I think that there is no other way than the real meeting people in order to keep the project and our relationship going on. So I think that we should start the meeting. Otherwise,
okay, I have not yet. Just a second. I have a few more housekeeping issues.
Okay.
After this last session of our meeting, we will be sending out the post-test to each of the participants of this workshop. And we expect it by Thursday, 25, to be back to Benil, through Rita or Ashura, it doesn't matter, the same way that you sent it in the pre-test. Of course, this will be a requisite for the eligibility for the certificate, as we said. And I remind you that it is no pass or fail in this test. We just want the post-test handed back so we are able to assess whether this workshop was useful, whether we did manage to get through some ideas, and we did. It's a useful teaching media. So the only thing we require is to have a full file sent back so we can assess. If you didn't send in the pre-test, it's okay to send in the post-test also. So we have as many as possible, but of course that the most significant is a comparison between the pre and post-test that you did on the beginning of this workshop. So reminding you, 25 has to be back to Benil. And also Ashura and Rita, by 25, we need all the attendance lists so we can really give the certificates for those who have participated in all the meetings that we had during these 3 months. The place of the ceremony of the distribution of the certificates will be sent out later. I don't know even by myself. And I understand that Rita and Ashura and the ambassador are taking care of this. And whoever will not be able to join, will make sure you get your certificate if you are eligible. I also want again to thank Liraz for joining our group in the last minute, because she really had to make a decision in a few days. She has a small baby and she agreed to come and join our joint effort in working with you. And I'm really looking forward to come. So any clearing points from Rita and or Ashura at this point to make something clear?
No.
Okay. No. Okay. So is it possible to have once? Sorry. Yes.
It's likely that the handing over would take place at the conference room of Kumasi South Hospital.
Okay. Send us clear specifications and we'll be there hopefully in time.
Yeah.
And can I ask everybody to open the screen, the video for a half a minute to have a screenshot? It would be nice. Before we start. Okay. Okay, more. Okay. Okay, great, Justin. Okay, we have already lots of pictures. Okay, please. Okay, are you ready for more opening of videos for a second? I understand that it's data. Okay. I don't hear my gling, gling, gling. Why isn't that?
Ari, don't worry. I'm taking pictures also.
Okay,
so
it doesn't do the gling, gling for the
doesn't have
screen. Okay. Laurine, Wadwa, Dr. Dustin, please open your videos. Opsi, I know you, Rita, everybody. Oh, that's great. Okay. 30 seconds more and we are done, almost. If you are more than one on one video, just get on, put in your face. Okay. עוד לחכות, אילון? לא.
No, I think it's okay. It's fine.
Okay, so we are ready to start. We have two missions to complete this workshop. And one is a case presentation by the Suntreso team. And the other one will be my last presentation on transport and the communication with OBG. So Ashura, please introduce your speaker and we can start.
Yeah, so good afternoon. Suntreso, we are going to present a case of neonatal sepsis, which will be presented by our senior house officer, Fred, and then our nurse, Francisca. Fred, kindly share the slides.
אילון תנחה אותו, אני חושבת שהוא עשה לו...
Yeah. Hello.
Hello.
Yeah, please, can you see the slides?
No.
No.
No, you have to share your screen or to share the, I don't know what you're sharing now, but you're definitely not sharing the right, I think we see your desktop. This is what we see now.
Okay, this is not my desktop.
Do stop sharing for a second. Do stop sharing.
Yeah.
And do it again. Share screen, and then you go to the left upper corner.
Yeah, this is not my desktop.
Benil, can you stop the sharing? It's Francisca desktop. Can you? Okay, Fred, share your screen now.
Okay. Please, can you see?
Yes.
Now
yes.
we see. Excellent.
Okay, good afternoon, everyone. I am Frederic Nkegbe Achu, a senior house officer from Suntreso Government Hospital, Pediatric Department. I'll be presenting with Francisca Kwaboa, a pediatric nurse. Francisca will start with the presentation and then I'll continue.
Hello, good afternoon.
Hello.
We are presenting on baby RT, a male baby who was 20 days old, born on the 9th of January 2022, came on admission on the 13th of January 2022 with a birth weight of 3.2 kilograms and was discharged on the 28th of January 2022 with a discharge weight of 2.935 kilograms. Next slide, please. On the chief complaints, baby was delivered vaginally to a now para 1 mother who was referred from a Groupon Health Center to a facility on account of yellowish discoloration of the eyes with 2 days duration of high respiration of 68 cycles per minute and hypothermia of 36.1 degrees Celsius. On perinatal and labor history, we gathered that the mother was 20 years old, Davida 1 para O, now para O. And then the mother had no known chronic illnesses. With the serology investigations, the mother was negative for syphilis, negative for retro screening, which is the HIV, and then was O positive. With the initial hemoglobin check, it was 7.6 grams per deciliter, and it was repeated to be 9.8 grams per deciliter. And then at 28 weeks, she had 12.1 grams per deciliter. The mother was on TAP, fesolate, and TAP folic acid during pregnancy. And she had 6 ANC visits, and she was booked at the hospital for 14 weeks of gestation. She took 1 tetanus toxoid and then 3 doses of sulfadamine parametamine, which is the malaria prophylaxis in pregnancy. She had no complications, and then she was able to carry the baby to term. She had prom for 18 hours with 3 vaginal examinations with no fever. Communication prior to birth, this was gathered from the referring site. Patient walked in with a referral note from a Groupon Health Center, accompanied by the sister-in-law. There was no communication at all between a Groupon and us. They just walked in. On the delivery room presence, we were told from the referring sector that there were 2 staff midwives available. Next slide, please. And these are the preparations with the equipment they gathered for birth. They used gloves, penguin suction device, ventilation bag and mask, alternate heat source, which I think it was a bulb. They didn't have the radiant warmer as we had. Cord sheets and cord cutting scissors with cord clamp. A minute, please. Come.
Hey, take a minute, and take care of this mommy wanting baby.
Calm down, come. Let me take this. Let me take this. Sorry.
Okay.
On delivery room,
Okay, it's okay.
Baby was delivered on the 9th of January 2022 at 12:33 p.m. at a Coupon Health Center at gestation of 40 weeks plus 6 days. And Nolip at 40 weeks plus 6 days in the active phase. It was delivered via SVD with APGAS 8 on 10 and 9 on 10. With resuscitation events, baby cried at birth and did not require any resuscitation. On NICU details, admission details, on arrival at our facility, the referring diagnosis was neonatal sepsis and neonatal jaundice on the 13th of January 2022 at 3:34 p.m. with initial vitals as follows. Heart rate of 138 beats per minute, SpO2 98% on room air, temperature of 36.1 degrees Celsius, respiratory rate of 68 cycles per minute, RBS of 4.4 millimole per liter, respiratory distress score of 1, and then between 6 to 80 on the distress score sheet. With a physical assessment, which was done at MBU by us as a nurse, we gathered that the airway was patent and maintainable. There was no obstructions or secretions at all. Breathing was spontaneous with SpO2 of 96% on room air, respiratory rate of 68 cycles per minute. On circulation, there was warm extremities indicating there was no signs of shock, and then heart rate of 138 beats per minute. On disability, baby was alert and conscious with temperature of 36.1 degrees Celsius. With exposure, baby presented with yellowish discoloration of both eyes, with body weight of 3.025 kg, hair circumference of 33 centimeters, and full length of 49 centimeters. Next slide, please. These are the initial problems and interventions we observe. We observe a yellowish discoloration of both eyes and concluded on neonatal jaundice. And then we intervened with empirical phototherapy, started as we were waiting for the SBR results. And with a tachypnea of 68 cycles per minute, samples for full blood count and blood culture were also taken. Samples for FBC and blood culture was taken to start treatment and also to confirm a diagnosis. Hypothermia of 36.1 was also observed, where we started skin to skin. Hello.
Fred, your sharing got disconnected somehow. Can you reshare the screen? Great.
Hello.
Fred, we don't see your screen yet.
Okay, I'm coming.
Isaba, take her away. Just take her away.
Please, can you see the screen?
We see the screen now.
Okay.
Now we see the presentation. Great.
Okay.
Francisca, you can try to continue now.
Okay, let me take this again. So for our initial problems and interventions, we gathered the baby, that the baby was jaundice with yellowish discolorations of the eyes. So we intervened with empirical phototherapy started whilst we wait for the samples or the labs to be ready with. And we also gathered that the baby had high respiratory rate of 68 cycles per minute, where samples of full blood count and blood culture was taken to confirm diagnosis and also to start treatment. Hypothermia of 36.1 was recorded, where the baby was kept warm skin to skin for a period of 1 hour to improve the temperature. Then the doctor took it from here. So Fred.
Okay, so from our assessments, the airway was actually patent and maintainable. And the child was breathing spontaneously with a respiratory rate of 69 cycles per minute, saturating at 96% on room air. On auscultation, the air entry was adequate bilaterally and breath sounds were vesicular. The extremities were warm to touch, indicating there was no signs of shock, with a heart rate of 132 beats per minute. The first and second heart sounds were present with no murmurs, and capillary refill time was less than 3 seconds. The child was also alert and conscious with all the reflexes being present, especially the suckling and the grasping reflex. On examination of the child, it was a male neonate who was not pale but etheric and was afebrile with a temperature of 36.1. Tones were normal in all extremities. The abdomen was full soft, moved with respiration. The umbilical cord was also clean and dry. There was no organomegaly on palpation. So our NICU admission details, the problems we encountered was that the child was jaundice, was hypothermic, and had tachypnea. So with the jaundice, we took samples for serum bilirubin ratio, GCSPD, and we started empirical phototherapy. For the hypothermia, we actually did skin to skin to improve thermal care. And with the tachypnea, we took samples for full blood count. And then on the third day, we took samples again for blood CS. We started our empirical antibiotics based on the protocol at our facility, the IV cephalosporin and an IV gentamicin. And for feeding, we encourage mother to put to breast, and we made a diagnosis of neonatal sepsis. Initiated IV cephalosporin, IV gentamicin, and then the blood culture results came out and grew Staphylococcus aureus, which was sensitive to amikacin, but resistant to ampicillin. Thus, we actually gave flucloxacillin, which was started due to its cost effectiveness. So the doctor's orders and measures which were monitored on the baby was that we took samples for full blood count, blood culture and sensitivity, serum bilirubin ratio, GCSPD, and we started empirical phototherapy. We also initiated 2-hour vital monitoring, especially the heart rate, the respiratory rate, oxygen saturation, and the temperature. We gave IV ceftriaxone 151 milligram 3 times daily, IV gentamicin 12 milligram daily for 3 days. And the baby's temperature was high, so and still had fast breathing after the 3rd day of starting ceftriaxone genta. So we switched to cefotaxime of 160 milligram for 5 days. And after 5 days, we started, by then the culture results were in, and we started IV flucloxacillin 80 milligram QID. And on the 3rd day, we discharged the child on oral. The mother was also encouraged to put to breast. So with our NICU clinical course, the medical problems which were requiring continued MBU admission and management was that the child had continuous temperature irregularities. The child was jaundiced and tachypneic. With physical examination, there was a male neonate who was afebrile but etheric, mildly pale and well hydrated. The cord was dried and clean. With our laboratory analysis and diagnostic testing, we did blood culture and sensitivity, which glued Staphylococcus aureus. The serum bilirubin ratio on initial day of presenting, that was on the 13th, was 23 milligram per deciliter. GCSPD was no defect in the full blood counts, which the results would be on the other slides. I'll explain. So there was no desired laboratory testing or imaging which was done, but the treatment which was given was the antibiotics, basically IV ceftriaxone and then gentamicin for the first 3 days, and then cefotaxime for 5 days, and then we continued with oral flucloxacillin. With our family-centered care, the mother was present throughout the admission, supported by the sister-in-law, but they couldn't afford some of the medications. So I want to talk a little about the labs. So on the day of presentation, the samples we were taking, the full blood counts, the WBC, that's the white cell count was in the normal range. That's 14.36, with the upper limit being 15.
Fred, did you stop the presentation on purpose?
No, I haven't. Oh,
it went out.
You stopped sharing for a
no. Yeah, it went out. Sorry. Okay. So should I continue from NICU clinical course?
from the
Please,
lab.
can you see the slides now?
No, not yet, but
Not yet.
We stopped seeing
From
the
the lab.
slides from the labs, yes.
So please, can you see the slides?
Not yet. Frederic has started screen sharing. No, it went out again.
Sorry.
If you want
Okay.
to send me the slides, and I can share the screen.
Okay. Please, can we see?
Yeah, now we can see.
All right. All right. So so on the day of presenting, that was on the 13th of January 2022, we took samples for full blood counts, and then the WBC was normal, that's 14.36, with the upper limit being 15. Hemoglobin level was 11. That was normal. That's the lower border. It was just marginally normal. And then the platelet count was also normal. 200 count was also normal, 5.36, with the upper limit being 7. A lymphocyte was marginally elevated. That's 6.04, with the upper limit being 3.7. And with our serum bilirubin level, SBR was 23.6 milligram per deciliter, which indicated on the Billy app that we should start phototherapy. GCSPD was no defect. So we couldn't repeat GCSPD the following day because the mother had financial constraints. So on the 16th, that was on the 3rd day of under phototherapy, SBR 2.6 milligram per deciliter, and on the Billy app indicated that we should stop phototherapy. but the repeated blood count and the BBC was still in the range of 818. Limiting. HB was 9.9, which was low. Neutrophil count was 3.48, which was normal. And then lymphocyte count was also marginally elevated. So the temperature pattern during the course of admission. So on admission, we initiated and started empirical phototherapy. The child, there was a spike in temperature around between 6 p.m. to 10 p.m. Temperature persisted. By then we started the IV cephalosporin and gentle. Temperature persisted, and then we've also taken the blood for culture and sensitivity. And then on the third day, we switched from the cephalosporin gentle to cefotaxime. So that will be on the 16th. Then from the 16th, 17th, 18th day to 9th, culture result came on the 20th, and we started the flu clocks, IV flu clocks. The temperature started dropping gradually to the normal range of 36.5 to 37.5. And we discharged the child on oral flu clocks on the 27th. Yeah. So this is the weight trend during admission. So the child actually came to our facility on the 4th day. So the birth weight was 3.1 something. But on the 4th day, we recorded a 3.09. And then there was a gradual drop in body weight, which is normal. On the 12th day, there was a drop in body weight to 2.5, and it's gradually picked up to on the 18th day of discharge, which was around 2.9 there. Okay, so the outcomes we had was that the baby was out of phototherapy on the 4th day of admission, and then the baby was discharged on oral flucloxacillin. The mother was asked to come for review on the 4th of February, but unfortunately did not report. Our strength was that the receiving MBU staffs were up to date. There was also readily available equipment at our MBU, especially our phototherapy. And then our senior colleagues, that's our bosses, the pediatricians, always came around. There was also complaints from the compliance from both the mother and then the family. And baby was out of phototherapy, and baby was able to feed very well. We had little challenges though. There are few. There was no communication between the referring facility and MBU prior to admission, and there was also the financial constraint on the part of the mother, making it difficult for us to get access to them. So thank you.
Okay, thank you very much, Dr. Fred and Francesca. Especially Francesca, I know one of your child is sick since yesterday, but you still got time to do the presentation. So please, if you have any question or you have want to discuss, we can start now. Thank you.
Can you stop sharing your screen, please? Can you stop?
Can you stop sharing? Neil, can you stop the sharing?
Okay.
Can I ask a question, because I got a little bit lost? The baby was not born in one of the MBUs. He was not born in Suntreso. Am I right? He was transferred from another place?
Yes.
Okay, and at what age was he transferred? Or he came from home? He was discharged from the other hospital and went home and then arrived to the hospital?
So the
Fred,
baby
can you
arrived at
answer
our
that,
facility on
please?
yes, the baby arrived at our facility on the 3rd day.
So the baby, I think Fred's network is not good. So the baby was well at birth and was discharged home and went back with a yellowish discoloration of the eyes, and that's why they refer to Suntreso.
So he went to the hospital where he was born, and from there he was sent to Suntreso. Am I right?
Yes.
Okay, and how far is the hospital where he was born? How far is it from Suntreso?
It's quite far. Akropong, I think it's like 2 to 3 hours from our place.
Okay, and did they have any way to check for bilirubin in the hospital from where he was sent to Suntreso, or they just they were concerned that he was yellow, or they were concerned that there was something else?
So they don't have the phototherapy at their facility.
No, but are they able to check for bilirubin, for transcutaneous
They also can't
bilirubin?
check bilirubin. It's a health center.
Okay,
health
fine,
center.
fine. I understand. I just want for those of us who are not aware to understand that he was sent because he was yellow, and at the hospital where he was born, they were concerned. I don't know if they were concerned also about the baby that was unwell, because you described the baby who had, well, mild temperature elevation, and he was a little bit tachypneic, right?
Yes.
Yeah.
Okay. Agi, you want to say something?
Yeah, I have questions. Many questions arrived. Thank you so much for your presentation, first of all. There are many questions rising
Especially
from
thank you to Francesca, who managed
Yes.
to present with a child on her knees. Not easy.
I'm starting from the end. You said there were the weaknesses were challenges in communication, like you didn't know a baby was coming in. And I wonder, because it's a topic of my next presentation, what do you think are the problems that a baby is sent from somewhere to your center without informing you that the baby is sent to your center, and that you do have an open bed and phototherapy available for him?
So let me try. Okay, Fred, go ahead, please.
Okay, boss, you boss talk.
All right, so for now, what we have started in Ashanti region is that we have a referral platform that we are expecting everybody to put the case on the platform, and then the pediatrician on the platform will decide where the baby can be sent to, depending on the availability of bed, phototherapy, and then the distance from the referral center to the referring facility. But unfortunately, we don't have everybody on the platform. We have most of the hospitals. But when it comes to the health center, some of them are not on the platform.
It's
But
a
they
WhatsApp
also
platform, Ashura. Is it on WhatsApp? How is it working?
It's on WhatsApp. It's an WhatsApp platform.
Amazing.
That has, yes, so all, including Confanochi. So, and from time to time, all of us will say how many beds you have, if you have phototherapy or not. But the unfortunate thing, some of the health centers are not on that platform, and private facilities are not on the platform. So, yeah, so that's what we have tried to do as a region.
It sounds very good, and if it works, it's even better.
Yeah.
The second question is, the baby was 4 days old on admission, looking healthy except of the color. what other signs made you suspect sepsis? It's an early onset sepsis by definition, which means a vertical transmission from mom. And at day 4, the baby getting sick, as we had the presentation last week, what other signs? Did the baby had any skin lesion? Did you see anything that the baby was healthy?
Yeah, but the baby had tachypnea. So we used, there is the increased respiratory rate was our main focus. And then from the history, the mother had three vaginal examinations, and she also told us that she had rupture of membranes of 18 hours duration. She was not really specific, so it looked like it was more than 18 hours. So we used those two, in addition to the clinical sign from the baby, which was tachypneic, to make our diagnosis of neonatal sepsis.
Okay, so really 18 hours was one of the risk factors. It was a term baby and a slightly elevated temperature, which can be environmental or something, and of course causes a tachypnea, a little tachypnea. So the signs of sepsis were very mild, the clinical signs of sepsis, as I understand. And Staph aureus is a very bad bug that can easily cause a disseminated disease. And I wonder, did you have any sign of a disseminated disease of?
No.
And the number of days of treatment for Staph aureus sepsis is, how long would you give him antibiotics?
Okay, so we're to give for 14 days, that's 2 weeks, but the mother was also having financial constraints, and the more the mother stayed on the ward, the more the cost increased. So we started the IVs, then discharged home on the orals to cover the number of days. Yeah. So we wanted her to come back on that review date for us to see if everything is clear. Yeah.
Fred, I have a difficult question for you. We know that even when we are taking blood cultures, we're not always sure that these blood cultures are true cultures. And when you have to look at this kid retrospectively, because we know very well that when we see a kid, a baby that is sick, we are always afraid that he's septic and we want to treat him and we want to save him. But looking at this case retrospectively, if we have to ask you between 0 to 10, how sure you are that this baby had real Staph aureus sepsis? Knowing what you know about Staph aureus and about sick babies, how sure you are of the diagnosis? Between 0 and 10.
I'll take 9.
Okay.
Okay.
Does anybody
have
a different?
Ashua, what do you think? You have a little bit more experience. How sure you are that this baby had sepsis?
Yeah, I'll go around 6. So we get many babies with sepsis. The blood culture grew staph, and they usually come very sick, but some of them are not too sick. It's mainly the temperature and high respiratory rate. Yeah. So it's like about 60%. I would not be very sure of stuff at the beginning, looking at the mouth presentation.
Well, I think without very close lab support, it's very difficult. I think what Elon is trying to say, it's also my opinion that we would take a 2 maybe for sepsis for this baby. The blood count was okay, and the temperature is not a good sign in newborns. Newborn babies are not, the temperature gives tachypnea, so it's 1-to-1. It always, the baby with fever will have tachypnea. The question is whether it's an environmental temperature or it's a real temperature. And very hard in your setup to diagnose sepsis, and maybe a repeat blood culture. We always have 2 cultures taken from a baby before starting antibiotics because of the possibility that it's a contamination. I know that it's a financial issue at your side, but again, we talked about how can we control the antibiotic usage in babies who might not have sepsis. I was very surprised hearing that the baby grew Staph aureus without being at all sick, and of course we don't know what happened, and I think a phone call would be a good idea. Today everybody has a cell phone probably to find out whether this baby is alive, because if he did have Staph aureus sepsis and got only partially treated, this is a very dangerous and disease for this baby. And I wonder, just for our outcome, to check our outcome, call the mom and ask her what happened with the baby. It will give you some feedback on whether
they did have a follow-up on the baby, but Fred, I want to...
She didn't come.
Oh, I want to tell you from what you heard from Ashura that was a little bit less sure about the sepsis of the baby. I think that you are also not very sure, because if you thought that this baby was a 90% chances of having sepsis, you wouldn't let him go home after 5 days of therapy. So it's understandable that at the beginning you are treating until you have a feeling of the baby, how sick he is. But you can ask Dr. Ashura, who has more experience. A baby with Staph aureus sepsis is extremely sick. It's an extremely sick baby. And probably if you do grow a lot of Staph aureus in your institution, you should go and check a little bit how cultures are taken and see if you can improve the way that they are taken, and that they are moved sterilely from the baby to the vial where it is collected, because it's one of the most, because if you take only one culture, it's very important that you do it as clean as possible in order not to get false positive results.
Yeah.
Okay.
Can I make a comment? So
Sure.
I totally agree with you. The problem we have currently is that the signs of infection, we still, I know the danger sign was not meant for the hospitals, but because of still we are having high mortality or infection being the 3 most causes of death in newborn, the threshold of us starting antibiotics in baby is very low. So usually we depend on the temperature, especially. So for now, any baby with temperature above 37.5, that when you expose that baby for at least 10 minutes, the temperature is still high, then we are required to start antibiotics. And this is because of the high mortality rate of infection in the country still. And with regards to going home, I don't know if Fred said it, I think for this baby, they had to send home because the mother was insisting she wanted to go home. And that is one among the challenges we are having at the MBU, especially when they are coming a little bit far from the hospital, because they don't have a place to store their food well and eat. And so they eat like outside. Their relatives have to bring food every day and it's very inconvenient. So usually they wouldn't want to stay in the hospital for more than even 5 days. So we are having a lot of challenges on that. And that's why sometimes you have to compromise and put them on oral medication. Yeah, so that's what I wanted to say.
Well, Ashura, you pointed out all the gaps that are so difficult for you to overcome, and and slowly to be overcome by the points that we raised.
Ashura, I want to show you your numbers, okay?
Yeah.
Because the paper that Dana eventually will finish writing, and you will see very shortly. From the babies that died in both units, in Suntreso and in Kumasi South. And we're talking about babies that were admitted during the first 3 days of life.
Okay.
From all the babies who were diagnosed, the main complaint was sepsis. None of them died.
Right.
None of the babies that the chief complaint was sepsis died.
Yes.
Okay? The babies that actually died were the one with low birth weight. Okay? These were the main babies that died. So you have to remember this, that your threshold of giving antibiotic is very, very low. But most of these babies, the one that died are the one that are with respiratory distress, the one that are low birth weight, and probably they also have sepsis, and this is why they die.
Yeah, and I think that's why we have been very aggressive in terms of sepsis, and that's why our survival rate is improving. That's what we think. So we think if we delay starting antibiotic, it might affect, because when you look at the whole country statistics, our mortality is quite low compared to other facilities or the national
Definitely.
rate. Yeah, so I'm thinking maybe because we have been very aggressive treating these babies, and that's why we are able to hit the 100%. I don't know if it could be we are over treating. Sometimes we even say we are treating our fears, but it's kind of when you see a baby with high temperature and you don't start antibiotics, you might not be able to sleep well when you get home. You'll be afraid. So that is the situation we are. We have not been able to have, let's say, good laboratory examination to see this baby really have sepsis or not. And we don't want to risk and say, oh, let me wait. We're afraid if you wait, something bad can happen to the baby, and we might not be able to intervene. And maybe that's why we have been a little bit aggressive when it comes to septicemia.
Ashura, you're 100% right. And I think that when it will be one of the topics you'll be discussing with Aggie when she comes to Kumasi. And I think that the issue is not of starting the antibiotic. The issue is to see that after a couple of days and to find the reasons why you can stop the antibiotics and say, okay, I was afraid, I treated the baby, but now I have a feeling that this baby maybe is not so sick and I can stop the antibiotics. It's something that you will have to learn how to do it. Now, we have another case, am I right?
No,
Yeah.
no.
No, it's
No,
one.
no.
Okay, fine.
I wanted to make one more little point about the growth chart that you presented, Dr. Frederic. It's I think it's much better if you take the daily weight of the baby. You should design some kind of graph that doesn't go down to the weight of 0, because you cannot really see the changes in weight. Am I clear what I'm saying? If you can share again your screen, you can if you have on the axis, y-axis, you go down to 0. You don't want this. You want to have a more easy way to see the daily changes by putting here maybe between 2.5 and 3.5, like down there should be 2.5 and up here 3.5, and then you can see the real changes in weight. Now, if it's true that this baby for 18 days did not change the weight at all, as you can see here, almost 3 weeks, which is still less than birth weight, then you might want to consider to assess the feeding of this baby, whether does the baby breastfeed properly? Does she get the amount necessary? Because this is not a healthy weight curve that you would expect in a term healthy baby. So as you described, the baby was sucking properly and was put on the breastfeeding, but this is the first baby of this mom. So this is, she would need some advice regarding the feeding if this weight curve. I hope that you are using the electronic scales that you have in your unit. So this shows that actually no change, or even no change in the baby's weight. So I would reconsider some kind of feeding advice to this mom.
Okay.
And another point, I didn't understand the admission results for the jaundice. The baby was admitted, how, and you received the results of the bilirubin, which was how high?
23.6.
That's 23 at day 4. And what happened after the daily progress? When did you repeat this bilirubin?
On the 3rd day.
Sorry?
We repeated on the 3rd day.
So when you have a bilirubin of 23 on admission, it requires that you know what is the next 8 hours or 12 hours to make sure that it's not higher than 23, which would need some other intervention.
Yeah.
Repeating, and you do have I hope it's functioning, the bilirubinometer that the unit has, in order to receive the same day result for the bilirubin. If you repeat only after 3 days, it is possible that in between the baby had a bilirubin of 30, and you should have had the exchange transfusion or any other therapy intervene. So I understand that after 4 days, it dropped to 6.6, but in between, we need a closer follow-up. Ashura, can you comment on the bilirubin if you have anything to add?
Yeah,
Okay.
so usually that is what has been done. We repeat bilirubin depending on the fast value, also the clinical features. Some of them, like routinely, we do daily for all who are jaundice, but some of them are very sick or we want to change.
Can you stop sharing the screen? Thank you.
Treatment. Yeah. So I really can't tell why this lady didn't do daily. They are paying. is not free. Our machine is still working. We get it from Suntreso a little bit. So sometimes looking at their financial constraints and your clinical features, if you see it's not getting worse, sometimes it's not being done, but usually we do it at least 24 hourly.
Ashura, we had, when we brought the machine, we said that I think a test of bilirubin should be not more than 5 Ghana cedis or something for the parents.
I think that's how it was, but currently,
very much affordable.
Yeah, now I think they charge, if I'm not sure, but I think they charge 15 cedis. Fred, is that the case?
Boss, 30 cedis.
How much? Yeah, it's 30 cedis.
30.
Yeah.
They signed an agreement, you know, the hospital manager.
So I'm happy when IT comes, maybe we can discuss about it.
No, we have this agreement signed. So even with the inflation in Ghana, I think that it was raised by 6 times. I don't know if the
Alberta say is 10 cedis rather.
It's 10 cedis. Okay, this makes sense.
Dr. Ashura is 10 cedis. SBR is 10 cedis.
Okay, it's 10 cedis.
Okay, we don't want to go into this at this point. I understand, and this is something which is echoing a lot, the issues that your medical decisions have financial constraints in different levels, either by laboratory tests or by medication, and this is very frustrating and in certain fields almost unacceptable from a medical point of view. We'll have to discuss what can be done and what medications are cheap and good. Those medications are very expensive, but gentamicin and ampicillin are good medications, as we said. So we see. We'll have this more discussions when I be there. And Dr. Frederic, I hope that our discussion is supposed to be constructive thoughts in looking feedback on a management of a baby, and you gave us a very clear picture, and Ashura completed the fears that you have to make sure that the baby is alive.
Yes.
Anybody else has any comment on the case? Okay, I advise strongly, again, going back to the lecture, wonderful lecture given by Winty on sepsis in the neonates, and develop protocols to minimize the use of the antibiotics whenever possible.